So now we will try to go into the question mode. So question mode means we'll try to discuss some practical situations as well. Are there any questions so far? Please feel free to use the chat box. Okay, I guess I have a very smart audience today. My students have become really, really good. That's real nice. Okay, so as we already said it, what about those things? What is DKA actually? It's a mix of hypoglycemia, DKA. D means hypoglycemia, K means ketosis is the A for acidosis is there, and of course associated with dehydration and electrolyte imbalance as well. So as I already said it about ketosis and acidosis, so what is happening is it is happening due to enhanced gluconeogenesis. Okay, because the body is thinking due to less insulin or no insulin, so body is thinking, oh, let's make more and more glucose because there's shortage of glucose in fact, and the glucose is coming from the gluconeogenesis. That's the process. Okay, and how is it happening is due to the lipolysis. So the lipid cells and all, they are getting killed in fact, due to which what is happening is those free fatty acids are going to be there, and that is the one which is leading to ketosis. And what are those ketone bodies is acetoacetate and BH, beta hydroxybutyrate. Okay, and as I was telling you, ketone bodies are the one which dissociate into the ketone anions and the H plus and ketone anions. And yes, so initial few time, yes, the body will be using its buffering capacity, and later on it is going to become problematic, and you are going to see the evidence of dehydration in the sense of, and it is happening is due to osmotic diuresis and also vomiting. The patient will be having all these problems, and there will be associated electrolyte imbalance, as we spoke about, is they will be having hyperkalemia, hyponatremia, even the phosphate depletion will be there, especially in most of these patients in fact. And the main reason for this is osmotic diuresis. Okay, and that is the one which is further affecting because of the lack of insulin. The final thing which is happening is affecting is the sodium potassium pump in fact. So I will try to summarize the new model. So what is this new model? In this new model they have tried to standardize the diagnosis about its treatment and what should be done, especially regarding the insulin, because there has been a lot of confusion going around what should be done, what not should be done, in fact, as well. So, what happens is there is a big variability. So, for example, if there is a young adult, there is a old person, yeah, they can be even associated with cerebral edema as well. Someone may be presenting with pulmonary edema, even hypo or hyperkalemia as well, hypoglycemia as well. So that is the reason. So to arrive at a diagnosis, the key important thing is do a finger prick test, not just for the blood sugar levels, but also for the ketones. Similarly, when you're trying to see for the venous pH or the gas as well, it should be taken from the venous blood. Unless and until, and you should all again same way try to do for the ABG. In fact, okay. So whenever you're trying to see for the pH or the gas as well, plus levels, you should use the venous. In fact, unless and until you really need is a ABG. And now the emphasis on the urine ketones is much less. So as I had already said about some of those criteria for the high risk patients, low, medium, and high risk, right? So how do you differentiate the high risk patients? So as I had was already telling, ketones, if it is more than 6, high risk. Similarly for the bicarbs, less than 10, yes. The pH levels less than 7.1 or 7 in fact, or even the SpO2 is less than 92, and of course the Glasgow Coma scale, if it is less than 15, you got to be careful. Similarly, when you're trying to think for the standard fluid orders, you should try to, as I had already said, it is you have to keep on giving normal saline over 1, 2, 3, 4, 5, 6 hours, and add 40 millimole KCl to the second and subsequent bag if the potassium is going to be less than 5.5. So as I had already said it is, we are trying to keep the potassium level slightly on the higher side. So what about this fixed rate insulin? Why are we giving fixed rate insulin? Because mostly in the ICU setup, we are used to giving the sliding scale. But as I said it, till the time you are able to resolve the ketoacidosis, you should not. And what type of insulin you are going to use is act rapid, that too in the standard concentration. And you should not switch it off until you switch it off. Okay? And as I was telling you, so after that, you continue the basal insulin regimen in the form of Lantus, Protophane, or Levemir as well. And you may consider the cardiac basal pump function. And as I said it previously, you have to restart the usual subcutaneous dosing and then switch off the infusion. So let's try to give you an example. So this is Mr. JL, which is here, 63-year-old gentleman with diabetic type 1, diagnosed at the age of 14 years. And he never had any DKA episodes and all. No history of DKA. But he's having a known case on chemotherapy for the metastatic colorectal cancer. And he was having recent episodes of chesty cough. In fact, one associated with reduced conscious state as well. And you try to do those. So the gentleman comes to the ER. You're called up. You have a look. Heart rate is pretty. He's tachycardia. SAT levels are like 90%. Blood pressure is feeble. Systolic is like 80. Yeah. And then thyroxine levels are pretty good, but pH when you do, it's 7.19. PCO2 levels are 26. Bicarbs are 39. Sodium is fine. Potassium is 5.9. Creatinine is 185. And the finger prick ketone then you do, and it's 6. So what do you do? So what do you observe? So by seeing this clinical picture, what do you think? Please use the chat box. So, okay, I'm already getting some answers as well. Okay, let's try to break the suspense. So, what happens is the ketone levels are going to be more than 6, as we have already seen. These, if we look carefully at these investigation rate, so we can already, one of the first things which we all should always do is classify the patient into the mild, moderate, or is it severe decay, in fact. So when we look at all these things, so we can already know the patient is definitely severely unwell. So the standard protocol does not apply, okay? But protocol should not be, just put it in the garbage. In the sense, it is very important. So what happens is, as we had already said, it is there are several changes in the protocol as well for such kind of patients. In the sense, you should try to put it in a not in an inpatient but in an intensive care unit. In fact, you must monitor the patient carefully. Try to maintain a strict fluid chart, as I had already said it. Uh, In the initial hours, you should give more and more fluid. Okay, 500 to 1 liter, half to 1 liter, in fact, per hour, in fact, as well, especially in the earliest phases, definitely. And in the meantime, keep on monitoring the input output chart as well. As I had already said, some of those patients can be dehydrated even up to 3 to 6 liters. So you have to be giving them more and more fluid, especially in the earlier time. And as I already said it, initially you must monitor them regularly on a hourly basis. And once you are able to stabilize the sugar levels, so the sugar levels are going to be around like 200 at least, or 150 to 200, then every 2 hours, by the time if the ketosis also settles down, the and you are able to see the H plus gap as well. So only after that. But in the meantime, what was the important thing was two things. You must give fixed dose insulin, no sliding scale, fixed dose insulin. And then the other thing is, so for example, even when we are trying to measure the ketone measurement, it should be done with the finger prick, not with the urine. Okay? So these are some of those important things which has been changed in the new protocol, which should be adapted. So this is another patient as well. You can have a look on the history. So what do you think once you look at this? So this is a 30-year-old male patient, a known type 1 diabetic. He has a history of polysubstance abuse as well, and he's coming uh, with abdominal pain, and when you try to do as well, when you try to see on an observation basis, it's normal, okay, but see for the do for the ABG. On the ABG, you notice is the pH is it is acidotic, in fact, like 7.28. PCO2 is 37, and the bicarbs is 17. On the electrolyte side, you notice like sodium levels are like okay, not bad, 139. Similarly, potassium is like 4, creats are like 16, in fact, and the ketones is 4. So, what do you think about this? Please use the chat box. I would like you to use the chat box and answer what do you think now when you see such kind of history. See, this is the important thing being in medicine. We are always a physician. Whatever you are, a cardiologist or uh, whatever specialist you become, we are always a physician first. And then our specialty comes. So, those basic, I would say, emergency things we should not forget. Okay? And why is it important is? So, same thing as I had in my last session on arterial blood gas analysis. I hope you all will remember, which we had already spoken about these calculating those the gaps, in fact, the electrolyte gaps, what how to do that, how to take care of that as well. And this is a little bit slightly extension. There's a big role for such kind of things, electrolyte imbalances, even in diabetic ketoacidosis management as well. And that is the same thing what we are trying to do it over here. So what do you notice over here? Hmm? I need an answer from everyone because we spoke about it, right? So, what do you think? What is happening over here? So do I have to leak the answer as well? Okay. So what happens is again, as I had already said, it is whenever such patient comes, always try to look out for the clinical signs and symptoms. In fact, and then you have to first of all, the first thing always try to do is to classify such patients. What type of severity of the DKA is it? Mild, moderate, or severe? So once you get these clinical parameters and the blood investigations and urine investigations and those electrolytes as well, so what do you notice? So you notice is the patient definitely has not severe, not moderate, but mild diabetic ketoacidosis. And when you are thinking for those high risk factors, they are not at all. Patient is normal, consciousness scale is there, Glasgow coma scale as well. It tends to does not favor that the patient is any altered mental state or something as well. So when you are trying to think, the standard protocol which we already spoke about, that will be something really nice. You can think of using for the patient for the treatment. Okay. So one of the key things I would really like you all, okay, my slides are of course going to be there, which you all can use for reading, learning, and relearning as well. So I would really like you all to go through this British Diabetes Society guidelines for the management of DKA, so which came in like around 2011 in diabetic medicine. So it's really a beautiful summary of all the things which you all should be using. And even recently as well from American Diabetic Association as well, there has been guidelines which is there. I would really like you all to go through these guidelines, and as I said it, try to learn more and more, and this is the things which is definitely going to be very much helpful as well. So this is something very important. Okay.